Let's move on. And DR, we are really looking forward for this because this is at the moment, ultimate technology that you're going to share with us. And we are interested to know your experience and the control that you achieve using this. So DR, please go ahead.
Is my screen seen?
Yes. I mean, you are saying all right, but not your presentation.
Oh, just 1 minute.
You need to share that.
Is it okay now?
Yes, you can.
Thank you so much, Dr. Abhay. I learned a lot as usual. I am supposed to be covering a specific aspect of phacoemulsification technology that we're discussing today, and that about Active Sentry. And I think I have been enjoying the benefits of using the Centurion system, though I acknowledge the presence of equally good systems that is available, multiple platforms that are there. Some of the great features that comes in the Centurion is not the gravity-assisted fluidics with the compression plates in the back bay, which allows the explicit control of the amount of fluid that goes into the anterior chamber, the dual segment pump and the 7 hub rollers that allows seamless aspiration of the fluid from the intraocular milieu, the optical pressure sensors, the irrigation pressure sensors, the aspiration sensor, and the back bay pressure sensor, which are constantly talking to each other, providing great control. And the low compliance tubings, this is from the Infinity, this is from the Centurion. The external diameter of both are the same, but you can see the internal diameter is much less, it's a much thicker tubing. So it's a minor variation in as far as the engineering aspect is concerned. It does play a great role as far as reduction in surge is controlled. What has come today is a sort of an icing on the cake. That is the technology of Active Sentry. In the subsequent part of my presentation, I would essentially be dealing with this. So what exactly is this Active Sentry? It's nothing else but a irrigation pressure sensor that has been incorporated in the proximal end of the phaco probe over here, and because of which there is a continuous maintenance of a stability even across varied vacuum levels. And this reduces the cumulative dissipated energy, phaco procedure times, and fluid usage. And this I will be emphasizing on in my presentation. So there are 3 cardinal aspects as far as Active Sentry is concerned. What is it that brings on to the table? One is the active surge mitigation, leakage compensation, and automatic patient eye level so that you do not have to make any kind of adjustment. What exactly are these things about? Basically, what has happened is initially the impulses, whenever there was an occlusion break, the information had to be transmitted onto the fluid management system, which is there in the phaco machine. And obviously, this used to have a travel in the speed of sound, but at the same time, this used to take a few milliseconds extra. Now, with the incorporation of the irrigation pressure sensor, in addition to the 3 sensors that are already there, the transformation of the information to the back bay pressure sensors as well as to the venting mechanism is much faster, because of which you get even better control than what was available with active fluidics alone. One of the most important factors that allows this Active Sentry to work effectively is the quick valve technology. Please look at this particular aspect of the fluid management system, that is the FMS pack that is there. Essentially, what happens is whenever you have full occlusion, there is a certain amount of collapse of the tubing, even if it's low compliant tubing. And when the occlusion breaks, then there is a certain egress of the fluid from the anterior chamber, because of which there is both the corneal endothelium and the posterior capsule move towards each other. So what the quick valve technology essentially does is to move the mechanism in such a way there is a certain amount of fluid injected from the reservoir that is there in the fluid management system in a matter of just about 0.1 to 0.15 seconds, so as to allow the collapse of the aspiration tubings not to be there and fluid not to be exiting from the anterior chamber, but the collapse is compensated by fluid being injected in the reverse direction, because of which the surge is mitigated to a significant extent And that is what the active surge mechanism is all about. And as far as the patient eye level itself is concerned, that was alluded to the earlier talk itself. It's important for us to understand that when you are talking about the patient eye level, we assume that the eye level of the patient is often at the same level of the cassette that's incorporated in the emulsification system. But the default setting is about -5, which means that's about 5 centimeters or 2 inches less. And each inch of the variation essentially introduces a variation about 2 millimeters of mercury as far as the intraocular pressure is concerned. So if you have a 5 centimeters variation, it's about 4 millimeters is the difference in the intraocular pressure. And in case the eyeball is situated a little lower, or the patient eye level is a little lower, and compensation is not made for it manually, the conventional Centurion or other systems, the amount of intraocular pressure is a little higher than what you have set prior to the surgery. What happens with the Active Sentry, because of the mechanism that's incorporated in it, there's no need for setting this eye level. There is an automated patient eye level detection, and the sensor automatically recognizes eye level, helping to maintain the consistent targeted IOP in spite of the patient eye level not being set in preoperatively. This is the kind of mechanism that takes place, whether it's above or below the fluid management system. The intraocular pressure that's maintained is significantly the same. The other important aspect is the incision leakage. We have all experienced this. I used to do all my cataract surgeries with a temporal clear corneal 2.2 millimeter incision. Today, I've almost completely shifted over to a 2.4 millimeters, because that allows me to introduce my phaco probe more easily. There's no crimping of the sleeve. Intraocular pressure, intraocular lens injection seems to be so much more controlled. Because of this, there's fluid leakage, not just from the main port, but even from the side port. And with the Active Sentry incorporation, the sensor automatically detects the difference in the flow and increases the irrigation flow to keep the intraocular pressure consistent. Mind you, this is not a dynamic process. Basically, it averages out the kind of leakage that is taking place, so that when there is average incision leakage, there is no fluctuation in the anterior chamber, and the preset intraocular pressure is maintained most often. This is the kind of leakage that is taking place, as you can see over here. And the Active Sentry ensures the intraocular pressure that you have set in the machine is maintained. I don't know how this slide came up, but this is my financial disclosure. Now let's look up some of the videos with the Active Sentry technology incorporated. As you can see over here, there's a fairly soft cataract, and it's already been pre-treated with a laser. What I've done is a sextant. And initially, when I thought I was introduced the Active Sentry technology, I thought this is going to be extremely useful when treating with difficult hard cataracts. But mind you, I've removed the capsule, and the hydro dissection that I do is there through the incision that have been created with the laser. I find that in my hands, at least, this sort of separates the fragments into complete pieces. And you can see the CD will remain 0 right through the surgery, because really you don't require any phaco power in these cases. But this is exactly the situation where the soft lenticular material goes ahead and tries to clog the phaco tip. And even we were talking about not having complete occlusion, but these are the situations where most often complete occlusion does occur, because there's no phaco power that's being used, and the soft material goes ahead and completely occludes the phaco tip. And often these are young patients. You have to be extremely careful of the fact that you don't damage the posterior capsule or cause any damage to the endothelium. Even though you're not using any phaco power in these cases, it is possible for these to happen. And the combination of the active fluidics with Active Sentry ensures that the anterior chamber milieu is well maintained. As you can see over here, the Active Sentry has been actuated 14 times in this particular case. That is, a surge even could have occurred in this particular case, but this has been preempted by the incorporation of the Active Sentry technology about 14 times, making the surgery so much more safer. And as you can see in this case, it's a high myopic patient, a post-retinal detachment surgery, the surgery having been done almost 20 years back. It was a buccal surgery that was done. It's a +1 diopter intraocular lens that needs to be implanted. The cataract as such is about grade 3, somewhat leathery cataract, and you can see adequate capsular excess being made. You can see the intraocular pressure. I keep at 20 in this particular case because I don't want the anterior chamber to be too deep. You can see certain amount of striations and folds on the cornea that's developing. That often happens when you keep the intraocular pressure very low. So that's the reason the most often I keep the intraocular pressure at around 30, which translates to a height of about 41. But in this particular case, I'm keeping it 20 because I do not want iris retropulsion to occur or the chamber to deepen. As you can see, in spite of the fact that it's a highly myopic eye, an eye which has undergone retinal detachment surgery, but the orientation of my phaco probe is fairly horizontal. This is because of the low amount of intraocular pressure that has been kept. And this, I'm able to enjoy a vacuum of about 600, aspiration about 34. The Active Sentry technology also, which is activated whenever it's needed, enhances the safety as well as the stability of the anterior chamber. As has been emphasized repeatedly, it's not really necessary to go on to a vacuum of 600 or 650 in each and every case. But the combination of these techniques allows you, depending upon the nature of the surgeon, the way that used to treating the cataracts, to use even low intraocular pressure, so that you enjoy the benefits of that. At the same time, use reasonable amount of aspiration vacuum, which makes the entire process of cataract surgery more efficient as far as the amount of energy that's going into the eye is concerned, safer, and leads on to clearer corneas and postoperative day 1. And that's the nucleus fragment that has been completely removed. The CD is about 9. That's less of an issue, but you could see the stability of the cornea, the anterior chamber during the entire procedure. Now it's you can see that buckle which is there, which is implanted almost 20 years back, and 3-piece +1 diopter intraocular lens is being injected with a good uniform rexus overlap. And in this case, the Active Sentry has been actuated just once. Obviously, even this is important, adding a further safety level over the active fluidics that we are all becoming quite familiar with. What about a small pupil situation like this? Dr. Vasavda also showed a nice case where he treated a small pupil situation. For me, there is a difference between a small pupil and a small rexus phacoemulsification. Whenever I have a 3.4 millimeter pupil, I'm able to run the rexus beyond the limits of the pupil and have a 4.5 millimeter rexus. I often do not resort to any pupil expanding devices, whether hooks or other expanders. And I find that with the right kind of parameters, you are able to do the surgery quite in a controlled manner. As you can see here again, the intraocular pressure is 30, where the bottle height is just about 41 centimeters. Aspirations remains at 32. I think vacuum is about 550 or 600 on the linear mode. And in spite of the pupil being low, you can see the intraocular milieu is quite stable. There's no fluctuation as far as the pupil is concerned. There's less tendency for the iris to flow into the phaco tip. And the pupil dilatation that was initially there is maintained almost right through the surgery. I'm often surprised at the kind of, I have made it a point, at least in my initial days, to have a look at this number of times the Active Sentry has been actuated. So it's an on-demand safety feature that you have. And in this particular case, I could do it even without it being actuated once. Passing on to a slightly harder cataract over here, which has been treated with the laser. Both the segmentation as well as softening of the nucleus has been done. What I do with my phaco tip is to essentially make a small groove and then subsequently do the chopping and along the lines which has been created with the laser itself. Each time I basically bury into the meat of the nucleus by going into the initial trench that I had created. I often find that it helps me, especially in the harder cataracts, to get a good grip onto the nucleus. As I already mentioned, during this stage, often I'm using only longitudinal phaco, and it's essentially only torsional phaco when I'm evacuating the fragments. As you can see here, all these activities are happening within the capsular bag. And I always make sure that depending upon the density of the cataract, I split the nucleus into 4 to 8 fragments, and the CD is also quite low. But as was discussed, when it comes to quadrant evacuation, even though I try to keep the plane as posteriorly as possible, most of it happens in the anterior chamber. And using effective parameters, reasonably high flow rate, low intraocular pressure, makes the fluctuation somewhat less in a system like this, where you have the advantage, the active sentry as well as the active fluidics incorporated in it. You can see there is hardly much movement as far as the phaco tip is concerned. It's directed in a horizontal fashion, sometimes directed posteriorly because of the confidence that you have. And this is a panoptic toric that has been implanted at the end of the surgery. And as this is just to re-emphasize the first video that I showed, here again, it's a fairly soft cataract. It's a sextant that has been made with the laser. And always, whenever there is a laser arcuate keratotomy, the first step I do is to open it up, because before I make the incision, I do not use the laser to make incisions, because I find that what I create with my blades are much better. Here again, it's the CDE will be absolutely zero right through the surgery. Obviously, we all know that you don't really require the laser even for these cases. As far as you are using the right parameters, the whole procedure goes well. And here, I'm surprised that the intraocular pressure is 60, but suffice it to say that most often it's 30. But sometimes when I'm faced with a very shallow anterior chamber, I do raise the intraocular pressure. You can see for a simple cataract like this, with the soft cataract, the number of times the active sentry has been actuated is actually 22. This sounds somewhat counterintuitive, because you think it will be the harder cataracts that it will be more often used. When you are dealing with a harder cataract, because we are quite comfortable with the usage of the foot pedal, we fluctuate between the foot position 2 and foot position 3. And as was discussed earlier, very often we avoid complete closure, complete occlusion. But when it comes to softer cataracts, where the nucleus fragments completely flow into the tip of the needle, there is more chances of occlusion, and that is when you find that this kind of active sentry actuation is more often seen. What about a total white cataract situation like this? Adequate capsular excess is done, and then subsequently I'm removing the whatever cortex and epinucleus is there. This trench is something that I do almost routinely. Here you can see I'm using a slightly higher intraocular pressure. You can see there's a PI that has been done here preoperatively, and it's a slightly shallow anterior chamber. Whenever I'm faced with a shallow anterior chamber, I do raise the intraocular pressure beyond the 30 to usually about 50, as you can see in this. The vacuum is about kept around 600. Then the fragmentation proceeds in a methodical manner. The chopping proceeds in a methodical manner. Subsequently, with the active sentry being actuated, you go ahead and remove the fragments that have been pre-created and implant the intraocular lens of your choice. Then when it comes to a posterior polar cataract, obviously hydrodelineation is something you avoid. And having an extremely stable anterior chamber in these situations is a great advantage. It was hydrodelineation that was done. Subsequently, this is a slightly fast-forward video, and the initial trends that I talked about, and no rotation of the nucleus, chopping of the nucleus. Essentially, the inferior heminucleus is chopped into 3 fragments. And without any rotation happening, essentially what I do is to remove this each chop in a methodical manner. Once there is debulking of the capsular bag, then this is a time when you can even go ahead, because there's no pressure on the capsular bag unless there's a pre-existing capsular rent. Then you can do a gentle viscodissection so as to reposition the nucleus fragment in the right place and go ahead with the removal of the nucleus fragment as well as the epinucleus and implant the intraocular lens of your choice. I think this is the last of my videos. Slightly a different situation, a very Morganian cataract. And once the capsular excess has been done, sometimes you have this situation where the small hard nut of a nucleus comes into the anterior chamber. This was an 84-year-old patient with a fairly unsteady posterior capsule also. Here, actually, even before I deal with the nucleus, I implant a multifocal intraocular lens into the capsular bag. And here, there's a dispersive viscoelastic that's being injected into the eye so as to coat the endothelium quite adequately. As we discussed earlier, here almost entire phacoemulsification is going to happen in the anterior chamber. But at the same time, it's not continuous application of the phaco. Unfortunately, the phaco settings are not seen here, but you have to take my word that the active fluidics with Active Sentry is in use. Basically, even in this, there's a right amount of changeover from foot position 2 to 3. And the phaco power is used only when it is necessary. And you can see the removal of the nucleus happening in a methodical manner. Of course, it's needless to say, there's frequent filling up of dispersive viscoelastic into the anterior chamber so that the endothelium gets protected right through the surgery. And that's the end of surgery. And I think last of my videos, which essentially just shows you the confidence levels that you have. This was a significant corneal stromal opacity that was there. Actually, we are planning on using a chandelier illumination system, but because of the red glow that was there, we dropped the idea. But once I stained, and when it came to nucleus emulsification, you can see the corneal opacity is significantly impacting the viewing. But even in a situation like this, I go ahead and use an intraocular pressure of 30, vacuum of 600, an aspiration of 32, because I have the faith in the system to ensure that there's no fluctuations. And you can most often achieve results like this with a good intraocular implantation with a regular overlap. So what essentially the Active Sentry has done is, apart from the icons showing up in the recording, you can see that icon in the Centurion system. And anybody who is having a Centurion can go ahead with the upgrade, which is both a software and a hardware upgrade, which essentially translates. It's not that you have to go ahead and stick to certain specific parameters. Depending upon your nature, the way you operate, the way your personality is, the way your results are, it allows you to drop your intraocular pressure, at the same time increase the vacuum and aspiration flow rate, so as to, in addition to the active fluidics, the Active Sentry is essentially an added advantage that we have in our armamentarium today. So essentially, it translates to a patient comfort. Most often, we are talking about surgeon comfort, the ease with which we are able to perform surgery. But when you have a low and constant intraocular pressure, the patient is also comfortable, apart from the surgeon, reduces the surge quite significantly. Less energy, heat, and fluid usage is there, which makes it friendly to the PC, endothelium, and the iris, so that the surgery is more controlled, more repeatable, and safer. Thank you so much for your kind attention.